Welcome to Aging Insight with your host, John Ross and Lisa Schollmeyer. This program is made possible by
Welcome to Aging Insight, everybody. I'm your host, John Ross, here with Lisa Schollmeyer, and she and I are elder law attorneys here in your area, and we try to assist folks through the aging process, from pre-retirement through the retirement, through old age, and all the way to the end. And essentially what that means is navigating through a maze of health issues, housing issues, financial issues, and legal issues that are all tied in together. And I bet if I were to ask each and every one of you that you probably would like to avoid nursing home care, you'd like to age on your own terms, independent and without being a burden on others, and you'd like to protect and preserve those assets that you've accumulated through your lifetime. And that's what we do, is we try to draw that path from start to finish to get you there with those goals in mind. Now, in doing that, there's just a million different things to think about.
Really, yes.
From the early stuff of talking about retirement planning and getting ready to retirement and making sure you're going to have enough income and when to take Social Security and your IRAs and all of that, all the way up to the other end of the spectrum, those end-of-life decisions. And that's kind of where we're going to focus a little bit today.
Well, you know, John, one of the issues that we deal with quite a bit with end-of-life care, and frankly, any care that you receive in your retirement years, most of our seniors are eligible to receive Medicare. And that is the health insurance and payor, I guess you'd say, program for our senior citizens age 65 and older. And so long as you have sufficient work credits, then you will be automatically, you're automatically eligible for Medicare at age 65. And so a lot of times as people get ready to retire, nowadays, most insurance plans that you had while you were working require that you sign up and take Medicare at age 65, and even if you continue to work, that your employer plan becomes your supplement. Now, of course, when you fully retire, you'll have Medicare, and then you may purchase a supplemental insurance program, and that is going to be your major payer for your health needs from retirement until the end of life. And John, last couple years ago, there was a discussion with the Obamacare and all coming in. One of the discussions was having Medicare reimburse primary care physicians for discussions with their patients about their end-of-life choices.
Right, and this blew up into a giant political mess, and it really was never intended to be. But we see an importance of people having conversations related to what type of care they want and what type of care they don't want. Because if you look out, they've done some surveys. Take, for example, CPR, and when you start talking about CPR, when you ask a bunch of ordinary folks out there and you say, hey, if you had a heart attack right now, would you want CPR? Would you want somebody to come and press on your chest and try to revive you? Well, in these surveys, when they asked ordinary people, 75% of them came back and said, absolutely, if I had a heart attack right now, I would want CPR. When these same surveyors then turned around and asked physicians, particularly physicians in a hospital environment, physicians who are routinely presented the opportunity to do CPR on people, only 5% of those physicians said that they would want CPR. So there's a complete disconnect between what the public perceives out there and what the medical professionals know out there. And the issue with all of this is that when it comes down to you deciding your own medical treatment, you need some guidance from those medical people. And that was kind of the whole thing with they were going to have with the Obamacare stuff was we were going to, right now the doctors are not paid to give you that advice.
Well, and to take their time and really sit with you and visit with you and get your very personal views and discussion. You know, there's no reimbursement for that. And you know, under basic economic rules, we all know that, you know, the services that get provided are the ones that there's some reimbursement for.
That's right. Now this got blown up into the death panels and all of that, which was that was just political wrangling at that point. But unfortunately though, it's still like that, where doctors are not paid to give you that advice.
Right. And so, you know, as a lay person, as a non-medical person, you know, I may watch medical shows, I may watch medical documentaries, and they've said that really the reason lay people or non-medical people want that type of, you know, life-saving treatment is because when you watch these shows, you know, everybody comes out fine in the end. You know, there's no handicap, there's no debilitating, you know, health issue that they walk out of the hospital with. And so it's not a realistic portrayal of what really happens with end of life or life-sustaining interventions.
Yeah, you know, when you talk about CPR, for example, in TV shows, roughly 75% of every time they do CPR on TV, that person that they did CPR on walks out of that hospital by the end of the 30-minute episode.
Right, just happy as a clam and heading off, you know. So
the reality is that if you need CPR, your chance of survival is only about 5 to 10%. Yeah. And of the 5 to 10% that live, only a portion of them will ever leave a hospital setting. The rest of them will have lost oxygen to the brain, and they'll be on life support or spend the rest of their lives in nursing homes. So there is a huge difference in all of these sort of things.
Right, and so you as a patient and as thinking about your life, you know, hopefully maybe our discussion now will cause people to just trap their doctor or nurse in the exam room and ask some questions about some of these things. But when we come back from our break, we're going to talk about some of the choices that you have, how those choices are communicated about end-of-life decisions, and then also, you know, what do your end-of-life choices, are they always followed, or is there ways that your own choices can be derailed, and how does your family come into all of this? So we're going to talk about those choices when we come back.
I'm so glad we found the Wadley Senior Clinic. Their team specializes in caring for older adults, and their doctors listen and work with me to keep me healthy and independent. With monthly educational programs, x-ray and lab, and state-of-the-art exam rooms, I get expert care and understanding about what I'm going through. Best yet, they're easy to get to right off the interstate at Jefferson. See what Wadley Senior Clinic could do for you. Wadley Senior Clinic, where healthy relationships begin.
At Advantage Senior Care, our goal is for seniors to stay home longer, stay healthy, and above all, stay happy. Our individualized plans are tailored to your loved one's needs, from meal preparation, shopping, and light housekeeping to bathing and dressing, mobility assistance, and companionship. Our trained caregivers will help maintain your loved one's independence while providing you with peace of mind. See how our family can help yours. Trust our locally owned and family-operated senior care service. Call Advantage Senior Care today.
Welcome back, everyone, to Aging Insight. I'm Lisa Scholmeyer here with John Ross, and today we're talking about a subject that can be a little touchy for people to think about and certainly to talk about, and that subject has to do with their choices about end-of-life care and medical interventions at that time. And you know, John, the first segment today, we talked about how there's a big difference between the end-of-life care that medical professionals say that they want and don't want versus the end of life care that non-medical people say they want or don't want. So there clearly needs to be some education there, but let's talk about the tools that are out there for you to express your wishes. Let's say we have a viewer who has gotten educated about the options and things out there. I mean, how do they communicate those choices?
Right. Well, and the one thing that frankly seems to be forgotten a lot of times is that you can tell people.
Right.
And that's somewhat joking, and yet many times in our practice we will have maybe we've got a son and daughter in the office with us, and they're talking about mom and what they want for mom and what they want to be done for mom and mom's medical treatment. And yet nobody has bothered to ask mom. It's not a case where mom's incapacitated to the point where she can't mentally decide. She may have some significant physical issues. Mm-hmm. But primarily what we're talking about is something called an advanced directive, a way that you can put those wishes in writing.
Right. And so, an advanced directive, and sometimes known as a living will, this is a written document that you list out the type of interventions that you want and those that you don't want at an end of life point. And there is a bit of a controversy here because I have spoken with community members who are concerned that signing a document such as a living will or an advanced directive will mean that should they ever be admitted to a hospital, then they won't be given the proper treatment because they have signed a living will. And in all my years of doing this, all I can say is that the medical providers under their medical licenses are to always intervene for life as opposed to no intervention unless a very particular set of circumstances are present. And those circumstances are that you're in a terminal and irreversible condition and the end of life is clearly imminent, or that you're in a permanent vegetative state. So this is not the type of document that, if you fall and break a hip, that you get wheeled into the hospital and they say, oh, you have a living will, we're not going to do anything. No, it's not. It doesn't cover that type situation. It covers that situation where that, the end of your life is imminent. It's really irreversible. The medical interventions themselves are not going to change that situation. And so that is what a living will talks about. What type of care do you want in those circumstances?
Right. What oftentimes people are confusing it with is the do not resuscitate order, which is a document that says, I don't want any life-saving tools. I don't want CPR. I don't even want you to try.
Right.
Just let me go. Those are appropriate in certain circumstances, with particularly people that have a terminal illness like a cancer or something. And if you've got a terminal cancer or something like that, and then you have a heart attack, it may not necessarily be appropriate to try to resuscitate you from a heart attack just so that you can turn around and pass away from the cancer. So DNRs are appropriate in those limited set of circumstances, whereas the living will or advanced directive, two phrases for the same document, advanced directive, living will, those are really appropriate for everybody because you're saying, here's what I want to happen when this time comes. And that can be very important, particularly so that not only will your wishes be carried out, but also so that your family will know what your wishes are. Because this can be a very emotional time for those family members. Their heart, their instinct is they want to keep you around a little bit longer. And sometimes those emotional side of them can override the logical side of them that says that there's really no hope in continuing or no point in continuing all of this. And that document that you've left behind can give them some comfort to be able to say goodbye with a strong will and know that they're doing what you wanted. So in all of these sort of cases, it can be very important. Now, regardless of all of that though, there's a million different types of medical situations out there.
That's right, and that's where a lot of times education comes into play, because we're lawyers.
Right.
So, and medicine changes every day, and it changes much faster than the law could ever keep up with it.
That's correct also.
So, when we talk about life-saving interventions or life-prolonging interventions, there's kind of a list that many of us as lay people are aware of, things like CPR or use of a ventilator, use of dialysis, feeding tube, those type things we may be aware of. But John, do you realize that in some circumstances the use of antibiotics would also be a life-extending treatment?
Sure. If I'm brain dead and I'm in a persistent vegetative state, and I'm never going to get any better, I'm just laying there, non-communicative, no brain function, but for whatever reason my body is continuing on. If I get pneumonia,
yeah,
then that's going to kill me.
Unless there's
unless
antibiotics.
there's antibiotics,
Yeah.
and so in that case, something as simple as an antibiotic can be life support.
And so there's a ton of different life support type interventions, and one thing I want to emphasize to our viewers is there's no one correct form of a living will. There's no, it's a very individual document to document your wishes. And so, if you find a form that's got check boxes and things on it, you should be able to include in that document anything that's very individual to you, that you have preferences about.
That's right. Now, here's the issue though that often comes up. When that time comes, and again, there's this myriad of medical decisions that are being made or need to be made, and even with the best efforts, you may not have covered every potential set of
Sure.
circumstances. It's just impossible. And so oftentimes those family members that are standing next to the bed, they're going to be the ones that are trying to decide if what you wanted and what your medical situation and how these two things fit together, and are they doing the right thing, and they're working with the doctor who's also involved in the treatment and all of this, and it's possible that all of these people cannot agree.
That's right. Disagreement is certainly a possibility.
Yeah, so what do you do then? Well, we're going to talk about that in our last little section here, so stick around after the break. We'll be right back.
At Advantage Senior Care, our goal is for seniors to stay home longer, stay healthy, and above all, stay happy. Introducing the Independence Check. A trained caregiver will visit your loved one in the comfort of their home, providing assistance with medicines, meal prep, caring companionship, and more.
Miss Smith, I just stopped by your dad's. He's taking his medicine and doing great.
See how an Independence Check can make all the difference in your loved one's day. Call Advantage Senior Care today.
The Wadley Senior Clinic has been such a blessing for our family. Because they specialize in geriatric care, they take the time to really focus on Dad's needs. Their exam rooms are specially designed for seniors, and they offer lab and x-ray on site. With monthly educational programs on health and wellness of the mind and body, our healthcare questions get answered. Best of all, they accept Dad's Medicare benefits. See what the Wadley Senior Clinic can do for you. Wadley Senior Clinic, where healthy relationships begin.
Welcome back to Aging Insight for our last segment. And we're talking about end-of-life decision-making, advanced directives, living wills, things like that. And right before the break, I mentioned, that there's no way you can put into writing every possible medical scenario that might come into play. And most likely, in all of these situations, you're going to have some loved ones, some family, friends, somebody who cares about you is going to be standing there next to that bed. And if you've done your job, you've prepared this living will or advanced directive that says, here's the kind of treatments that I would want or the ones that I would not want. But whether you have done that or have not done that, either way, there's a possibility that there ends up being a conflict between what the family thinks is appropriate for you, or what the family thinks you would have wanted, versus what the medical professionals think is appropriate under the circumstances. You know, and Lisa is in reading up prior to the show, I read an article, and it was talking about it was a doctor that was writing the article, and he was talking about a situation of a gentleman who was terminal, had lost basically all quality of life, needed a tremendous amount of treatment, and in order to continue living would need even more. Much of it painful and uncomfortable, and the doctor looked at it as, at this point, it's torture. We've crossed the line from medical treatment to torture if we do anything else related to prolonging this person's suffering. The family, on the other hand, is insisting that all of that stuff continue to happen.
Right. So, you know, and that becomes an issue. And what happens is, in this particular case, you know, a doctor makes recommendations. A doctor cannot, at this point, substitute their decision for the family members that, you know, have the medical power of attorney or the authority to make medical decisions. So, you know, a lot of people are concerned, and they do have a fear that the medical providers will make the choice for them as far as discontinuing any life-sustaining treatment. And certainly right now under our laws, that is not possible at this stage. The doctor, even if he feels very strongly that way, at that point cannot override the family. But there are systems in place for the family to move the patient to the care of another doctor who will provide that treatment they think is appropriate. There are systems in place for the current doctor in the facility to discharge this patient. And John, that gets into some procedures on how that has to be done and who gets to be notified.
Like so many things, there are rules.
There are rules.
And oftentimes, if you're talking about an end-of-life decision like this, if the family and the doctor disagree on the treatment, particularly if that is the family wanting to continue life-sustaining treatment and the doctor thinks that it is unnecessary or unwise or inappropriate, the doctor is required to get the opinion of another physician first, somebody who hasn't been involved in it. If that second doctor agrees with the first doctor, well, then the two of them are supposed to go and make the recommendation to the family. If the family still doesn't agree, then within most hospitals, because this is going to be something that's at a hospital typically, the hospital will have an ethics committee, a group of people made up of doctors, oftentimes a few community members, some nurses, some administrative staff, and the ethics committee will review the situation and decide whether or not they agree with the family or whether or not they agree with the physicians. If they agree with the physicians that the life-sustaining procedure should be terminated, then they can go down to talk to the family, and essentially they give the family an ultimatum. Lisa, they tell them, you have 14 days.
That's right.
To find another facility that will do what you want. And
Yes.
if you don't, or if you can't, then the hospital itself can in fact terminate that life support.
Right. So at that point, but you see how many things we've gone through before that could ever happen, and now we still have a 14-day period where the family, the life-sustaining treatment must be continued during this time, and the family has to find another medical facility and another treating physician that will take the patient and allow for the transfer of that patient into their care. And John, that can be a very difficult situation.
Interesting point on this, the state of Texas is required under law to maintain a list of hospitals or facilities that will take people in this situation. And they're required to make that a public list that you can access online.
Right. So there's a website out there.
So there's a website out there.
And John, how many hospitals are on that list?
None at all.
0.
There are none. So it is at that very end, at that point, it really is almost impossible. If you can't, you probably would not be able to find another care provider during that 14 days, depending on the circumstances.
Depending on the circumstances, but you will certainly have the opportunity as a family to do so. And sometimes, John, this gets into whether sometimes there's war within the family about, well, the patient would definitely want to be let go, or the patient would definitely want to have to fight on. So that can be an issue as well. So, when there's families, there's always interesting dynamics.
Right. All the more reason to get as much of this in writing in advance with good knowledge behind you, not just from the elder law attorneys. We're the drafters. It's the doctors who come up with the information and give you that medical knowledge. Then we help you put it in writing. That's what we do. Right. And of course, if you have more questions, you can always listen to our radio show every Saturday on 98.7 live at noon. You can pick up a copy of our Aging Insight magazine, or you can stick around until next week and catch another episode of Aging Insight. See you then.
Bye-bye.
Thank you for joining us for this week's Aging Insight program with John Ross and Lisa Scholmeyer. This program is made possible by